this is my outline, introduction down to the references, classification of antibiotics, general principle of antibiotics use, and the rest. So, as well of introduction, one of the greatest triumphs of modern medicine is antimicrobial chemotherapy. And this is based on selective toxicity, as they are capable of eliminating microorganisms without harming the host. Though penicillin was first discovered in 1929, the current era of antimicrobial chemotherapy commenced in 1935 with the discovery of sulfonamides. Other key people who played an important role in antibiotics include Louis Pasteur and Robert Koch in 1877, Alexander Fleming in 1928 when he discovered the penicillin. So antibiotics are microbial products that can inhibit or kill other microorganisms, while antimicrobial agents include antibiotics, synthetic and semi-synthetic compounds that can inhibit or kill microbes. Antibiotic is often used loosely to include all antibacterial agents as well, but this is strictly incorrect. Those that kill bacteria are known as bactericidal, and those that can cause reversible inhibition are known as bacteriostatic antibiotics. And it's important to note that the use of antibiotics is not the sole answer to infection in surgical practice, as there are other ways of curbing and preventing infections other than antibiotics. The classification of antibiotics, we have antibiotics based on the activity, based on spectrum, and based on mechanism of action. So based on the activity, we have bacteriostatic or bactericidal, like I said earlier. But for bacteriostatic, we have antibiotics that can cause reduction in the growth rate of organisms, and it competes with the organism for substrate by influencing the ribosome inhibiting protein synthesis. And examples of this include tetracycline, chloramphenicol, and the rest. So for bactericidal activity, these antibiotics act by direct destruction of the organism, and they exert their influence by disruption of the cell wall of the organism, as we'll see as we go on. And they include penicillins, cephalosporin, metronidazole, and the rest. So based on spectrum, we have the narrow spectrum, broad spectrum, and extended spectrum antibiotics. So for narrow spectrum, we have antibiotics acting on a single or a limited group of microorganisms. For broad spectrum, we have antibiotics which affect a wide variety of microbial species, which includes both the gram negative, gram positive, and yes, together, a combined a drug that can affect both the gram negative and gram positive. Then extended spectrum is an antibiotics that are effective against gram positive organism and also against a significant number of gram negative organism. So we have examples of narrow spectrum, which includes the macrolides, which are more sensitive to gram positive organism, vancomycin, penicillin G. Then the broad spectrum, which covers both the gram negative and gram positive, which includes cephalosporin, tetracycline, monoglycoside, and the rest. So, based on the mechanism of action, we have antibiotics that act as cell wall synthesis inhibitors. Now, the cell wall of a bacteria helps it to divide. It's an enclosing membrane that helps the bacteria itself to have its contents locked up within itself, and also it helps it to divide such that when it comes to multiplication of that bacteria, the cell wall helps it in the division. And so now we have bacteria, or rather antibiotics, that act as cell wall synthesis inhibitors. So meaning that what they do is that they act by binding to the penicillin binding proteins. Now, the cell wall is made up of peptidoglycans, and these peptidoglycans also made up of penicillin binding proteins, and they act by keeping the cell wall together. So, what this antibiotic does is that it inhibits the binding of the penicillin binding proteins, and it therefore inhibits the transpeptidation or cross linking of the peptidoglycan polymer. All in all, what it does is that it inhibits the cell wall. So by inhibiting it, they are unable to um, grow, or rather, they are unable to multiply. And we have examples such as penicillins, cephalosporin, vancomycin. Then we have protein synthesis inhibitors. So the protein synthesis inhibitors are those that have examples such as aminoglycosides, macrolides. So for aminoglycoside, which is a broad spectrum antibiotic, what it does is that it inhibits the protein synthesis by binding to the 30S of ribosomal subunits. Thereby, they prevent the formation and the initiation complex of messenger RNA, basically. So that's what they do. While for the macrolide, they act on the 50S ribosomal subunits doing the same thing. And we have other examples like the tetracycline, which also binds to the 30S ribosomal subunit. They are bacteriostat tetracycline is a bacteriostatic agent. Then moving on to the other antibiotics mechanism of action, such as the DNA gyrase inhibitors, RNA polymerase inhibitors. Both of these are they inhibit the nucleic acid. So they are nucleic acid synthesis inhibitors, basically. And RNA polymerase inhibitor is DNA dependent RNA polymerase. So that's what it does. It inhibits that. The next slide shows a picture of of the site of action of antibiotics. And we see, looking at the picture one, inhibition of cell wall synthesis. Examples include the penicillin, cephalosporin, the inhibition of protein synthesis, which includes erythromycin, streptomycin, tetracycline, and the rest. This is a diagram that just shows the different antibiotics, and I'll be speaking on just a few to save time. So we have the beta-lactam antibiotics. I'm going straight to beta-lactam antibiotics, where we have the penicillin, the ampicillin, amoxicillin, cephalosporin. So the cephalosporin is a broad spectrum antibiotics, and it has different generation of antibiotics. The higher the generation, the wider the coverage. So we have the first generation cephalosporin, which includes the cephalexin, second generation cefuroxime, third generation, we have the ceftriaxone, ceftazidime, and the rest. And so with the higher it goes, the more coverage it has. While for we also have penicillin, which we have different subtypes. We have the aminopenicillin, which includes the amoxicillin, the ampicillin. We also have the anti-pseudomonas penicillin, which includes the um, piperacillin. The general principles of antibiotics uses. Now, these are the principles that guides us in using antibiotics in surgery. So antibiotics are adjuncts and not substitute for indicated medical therapy. So in a situation where we need to excise, uh, should I say, or we need to drain a pus, we should drain a pus instead of just loading the patient with antibiotics, because the antibiotics will not have so much effect on the patient as when I&D is done. So they must be given in acute surgical condition until the diagnosis has been established and decision taken for against operation. And this is because antibiotics would mask the inflammatory process that could be ongoing while they come in the acute phase. And so it's better the antibiotics is not given, so they will know whether there is an acute condition ongoing, and they will be able to take decision whether or not to go in for the surgery. So antibiotics are more effective in the early cellulitic and hyperemic stage of infection before the onset of suppuration. So for example, in conditions like cerebral abscess, where we have the early cellulitic stages, it's better off when they are given antibiotics at that stage. But at the point where it's moves to suppuration, there's little or nothing that antibiotics can do. The best is just to go in and excise. So moving on to the next exercise, the most effective agent or combination of agents must be used and in sufficient doses and continued for adequate period, usually 47 days after symptoms and signs have subsided. So you want to know the specific organism that is causing the infection. It could be based on the normal flora of the body. It could be based on the sensitivity pattern of the environment, just to ensure that the specific antimicrobial agent is used, and it is used in sufficient doses, not less or not more, and for the adequate number of time. Some say 4 to 7, some other textbooks will say 5 to 7 days as the optimal period. A bactericidal drug should not be used in combination with a bacteriostatic drug because the effects cancel out. So, what the bactericidal drug would do is to act at the level of the nucleic stage, which would cause them which would kill them at that stage. And so, for a drug which will not act as a bacteriostatic drug in combination with the bactericidal drug, which would stop their multiplication. It will end up canceling their effect such that this drug has stopped the replication, which is the bacteria, or rather, the bacteriostatic drug stops the multiplication of the organism on one end, while the bactericidal drugs kills the organism and it acts on the, should I say, they act in the nucleic, that's the DNA point, where they act at the very center of the organism. And so giving them together would cancel out the effect. So all efforts must be made to avoid development of side effects of antimicrobial treatment, and they must be well understood before prescribed. So you want to individualize your antibiotic treatment in the sense that you want to look out for patients who would probably benefit from a particular antibiotic than the other. Then you want to look at for the side effects of the drug. Could be neurotoxic. A patient who will be on drugs like amikacin, you would want to check their kidney functions to ensure that they have good kidney functions before the commencement of a particular antibiotic. So, as treatment is in progress, physiological deficiencies should be corrected, e.g., treatment of comorbid infections like DM, correction of anemia, avoidance of steroids and other immunosuppressive agents, nutritional deficiency. All of these things should be corrected as treatment is going on because they in themselves can cause the patient to be immunosuppressed, and the antibiotics use would be of no effect if the condition that's causing them to be immunosuppressed is still in view. So they are more effective in controlling established infection than prevention. So moving on to the antibiotics use, antibiotics can be used prophylactically, it can be used as a therapeutic, and it can be used in other ways. So for the others, we have other uses of antibiotics include antitumor, which includes bleomycin, daxinomycin, could be used in radiotherapy, could be used as a board preparation, it could be used in disease like tetracycline, and so on. Then as a prophylactic, prophylaxis use of antibiotics is the administration of antimicrobial agents prior to initiation of certain procedures in order to reduce the number of microbes that enter the body as a result of the surgical procedure, or yes, in order to prevent anticipated infection. So the indications include clean contaminated and contaminated wound. So for clean contaminated wounds, you want to use a prophylaxis. Then clean wounds in certain conditions where infections could be catastrophic, like in neurosurgery. Then patients that are immunocompromised, surgeries involving implants, impaired host defenses, sorry, same as immunocompromised. Then principles of antibiotics prophylaxis, the timing. Now, the antibiotics should be administered 30 minutes to 1 hour before knife on skin and could and continued for not more than 24 hours after surgery, counting from the last skin suture. Now, the aiming at the saturated tissue concentration above MIC at the time of surgery or manipulation. The antibiotics basically must achieve concentrations greater than the MIC, which is the minimum inhibitory concentration of suspected pathogens. And these concentrations basically must be present at the time of incision. And so it's better done. Usually, they would say antibiotics is given at induction of anesthesia, such that the minimum concentration is reached um, at the time when the surgery is about to start. That is a time of skin, knife on skin. So the shortest possible course, ideally, a single dose of most effective and least toxic antibiotics should be used. Basically, these antibiotics should be given through the intravenous route and not orally. Local antibiotic sensitivity patterns should be followed. Selection is based on normal flora of the organism. So there are sometimes we want to repeat the dose of prophylactic antibiotics during surgery, and this includes procedures lasting greater than 3 hours, major blood loss, and also extensive burns. So there are some. This is a picture or a table rather, sorry, showing the antibiotic prophylaxis for GI surgery, and the recommended prophylaxis includes for the gastric, duodenal surgery, we could give cefazoline 2 grams. Basically, in our center here, we give them ceftriaxone, and we add, which is a broad spectrum antibiotics, and we add metronidazole, which it would cover for the anaerobic organisms. And for hernia repair, basically, it is not recommended. It's a clean surgery, but however, if we are going to be putting a mesh, um, um, we will be needing an antibiotics, although there are antibiotics impregnated mesh, which which could be used. Then for breast, we could also give antibiotics. Endocrine prophylaxis is usually not recommended. Then moving on to surgeries for the head and neck. Um, I'll just move to the next slide just to hurry up. Neurosurgery, we have procedures like craniotomy, any surgery in the head, basically, you want to give antibiotics because infection in that area could be catastrophic, like I said earlier. And also, you can add vancomycin to the antibiotics given. This is the antibiotic prophylaxis for neurosurgery. This is still for neurosurgery. Then for thoracic surgery, antibiotics. Mostly we give broad spectrum antibiotics, ceftriaxone, which is given in this facility, and metronidazole is added as well. So the NRC classification of surgical wounds, I just put this here to help us to understand the point where we can give antibiotics and where antibiotic is not necessarily needed. So for the clean surgical wounds, which is also known as class, which can be called class one. No viscous is open. Infected risk is less than 2%. Examples of this include herniorrhaphy. This what's it called? This procedure, or rather, this kind of surgical ones, do not necessarily require antibiotics, especially if the patients are healthy and they are not immunocompromised. So they can actually pass without an antibiotics, without antibiotic, except in the case where we use a mesh, like I said earlier. Clean contaminated, you in, which includes example uninflamed appendicectomy, sorry. Antibiotics can be used from this level downwards. Therefore, dirty infected, we would want to do other management of infection, which could include I&D, different methods of taking out the infection before administering or concurrently with the administration of antibiotics. So, for antibiotics use as a therapeutic, this is done to treat already established infection. We have the presumptive treatment and definitive treatment. So for presumptive antibiotics, this is an antibiotic given with the possibility that infection may occur. Then empirical antibiotics given in the event of an infection based on the likely organism without doing a sensitivity test. Then definitive antibiotics given due to culture and sensitivity result. I think this is self-explanatory, but basically, um, the indications include for therapeutic includes when when unexpected contamination occurs in dirty surgical wounds, in established infections, and treatment should be continued for a minimum of 5 to 7 days. So, for presumptive treatment, like I said earlier, the treatment is based on the site of infection. You want to know the normal flora of that particular area of the body. You want to have prior knowledge of the bacteria known to colonize that area. Then also the local bacterial resistant patterns or antibiotics. There are some antibiotics that you don't want to give alone because of the resistance that have been seen to occur with the antibiotics used alone. So you need to add an antibiotic, or rather another agent, which would be a synergistic act on the antibiotics, which will give an optimal treatment. Therefore, definitive treatment is based on microbial diagnosis. That is after a culture has been taken of the particular area and the sensitivity pattern is out, and the so antibiotic is prescribed based on the sensitivity pattern, and it also helps to narrow the spectrum of antibiotics that is given. So instead of giving a particular broad spectrum antibiotics, you could now give a particular antibiotics that will target the intended or the causative organism. So, and it also good as it helps to monitor the clinical progress, clinical monitoring of the progress. So principle of therapeutic antibiotics. You first of all want to establish a clinical diagnosis and a need for antibiotics based on the history and examination. Obtain an appropriate clinical specimen for the culture and sensitivity. Then remove barriers to cure. If there's a need for debridement, you go ahead to do debridement or sequestromy or I&D, and overall a good wound care. Then want to determine the most likely organism causing the infection, after which prescription or selection of antibiotics is done and the patient receives the antibiotics. So there are topical antibiotics that have that can be used to for infection, which includes the topical sulfonilamide on open fractures, large burns, and there are reasonable alternatives to parenteral administration for patients in shock. And also in neurosurgery, in spine surgery, they use the topical administration of gentamicin to curb the infection rates or any infection that could occur as a result of the procedure done. So selection of appropriate antibiotics would would want to first of all know the spectrum of action of the antibiotics we are using, the pharmacodynamics and pharmacokinetics of the agent. This will help us to know which patients will be needing which antibiotics. Then oral versus intravenous therapy. Like I said earlier, for prophylactic use, intravenous therapy is ideal. Therefore, the cost and availability, especially in areas like ours where cost is always an issue. Therefore, modifying host factor, you want to individualize your administration of antibiotics. There are patients with conditions such as GCSPD deficiency, you don't want to give them sulfur-containing antibiotic drugs. Then for renal and hepatic function, you'd want to withhold drugs such as amikacin, all the aminoglycoside from patients with renal impairments. The pregnancy and lactation, patients with allergy and intolerance as well would help us to make a good selection of the appropriate antibiotics. Then you also know the immune status of the patient, sensitivity of the organism to the drugs, basically. So duration for treatment. So for prophylactic use, it should be used within 24 hours, not more than that. 5 to 7 days for most pathogenic superficial infection, 10 to 14 days for established purulent peritonitis, 6 to 12 weeks for osteomyelitis, endocarditis, prosthesis. Basically, the first 2 weeks should be given intravenously. That's the antibiotics you should be given intravenously. After which, the same antibiotics is continued per oral for the for a complete 6 weeks in conditions like osteomyelitis and even cerebral abscess as well. So assessment of response to treatment, you also look out for certain things to be sure that the antibiotics given is actually working. So you'll be checking out the clinical parameters, which includes their general well-being, vital signs, standard swelling. You want to ensure that all the signs of inflammation is off or is gone. You'll be looking at the laboratory values to ensure that they have a normal white blood cell count. There are no polymorphonuclear cells. The procalcitonin level is normal. You want to ensure all of this. However, the imaging results is not a good use of how of an assessment of response to treatment because they usually lag behind clinical cure. So antibiotics resistance. Antibiotics, there are some organisms that are able to survive exposure to antibiotics due to some reasons, such as mutation or even acquired resistance. And it's a matter of great concern. So it's encouraged by the abuse of broad spectrum antibiotics and also poor dosage. And it can occur from production of enzymes, alteration in number of target sites. Basically, there are different mechanisms of action by which antibiotic resistance can occur. It could be due to transduction, transformation, or conjugation, depending on the type of organism. But there are some strategies that are listed out here that could help us to know how these bacteria can be resistant to some antibiotics. The first is production of enzymes that destroy the drug. There are
Dr.
some
Glory, you have 1 minute left.
okay, there are some antibiotics that produce beta lactamase, which would destroy the beta lactam ring. So additional drugs like clavulanic acid is used to inhibit this effect. Then this is overcoming the resistance. Then antimicrobial combination. So this is actually done to achieve bacterial synergism as the use of two or more antibiotics to treat mixed infections can prove to be more and significantly effective than just using one antibiotics. There's some complication of antibiotics include toxicity, changes in patients and hospital bacterial flora, pseudomembranous colitis. Common misuse of antibiotics, we have prolonged empiric therapy without clear evidence of infection, prolonged prophylactic therapy, failure to narrow antimicrobial therapy, which can be seen in our environment. Then antibiotic stewardship program. I just added this here just to remind us of this. It's a coordinated event that helps to improve the appropriate measure of antibiotics to be used, and it helps us to making a good selection of the antibiotics to be used. So relevance of antibiotics into surgery in West Africa. Patients, a longer preoperative stay. Most of our patients in this facility stay a long time before they have the operation done. Large multi-bedded ward, poor theater design, lack of operation, long operation time, and lack of infection surveillance committee. So our current trends includes antibiotics impregnated implants, antibiotics impregnated sutures, antibiotic beads, and use of biomesh. So in conclusion, preventing and treating infections needs a good understanding of the roles played by infective organism and host resistance. Use of antimicrobials should be guided by accurate diagnosis, pharmacodynamics, pharmacokinetics of the agent, and modifying host factors. Antibiotics prophylaxis is strongly recommended as it will significantly reduce length of stay in the hospital, post-op mortality, and cost. These are my references. Thank you for listening.
Thank you very much, Dr. Glory. You exceeded by 1 minute. So we'll follow the normal patterns. House officers, please, your comments and your questions.
What is prophylactic use of antibiotics, and what are the indications for the prophylactic use of antibiotics?
Use of antibiotics is use of antibiotics prior to surgery to help to decrease the risk of post-op infection.
So, what are the indications? The use of antibiotics and prophylactic antibiotics is mainly for clean wounds, and then some books
Clean
add clean
contaminant.
contaminated wounds. Naturally, for clean wounds, they're not supposed to give antibiotics, they're just supposed to ensure non surgical asepsis. In neurosurgery and orthopedic surgery, where or the effect of infections can be very catastrophic, yes, you display the use of antibiotics. Another indication is when there is going to be a use of a foreign body like an implant, pacemakers, you know, you should use antibiotics. So, what are the precautions? What are the things you do in prophylactic antibiotics? When is it given? When can it be repeated? When can it be extended? What kind of drugs are you giving? So, what are the package of prophylactic antibiotics, the do's and don'ts of prophylactic antibiotics? So, what are the precautions you'll be taking if you're giving prophylactic antibiotics?
Thank you, Chief. Um, in giving prophylactic antibiotics, you want to give it intravenously. It is
One.
given about 1 hour before the incision.
Okay,
So
people say 30
generally,
minutes.
okay, 30 minutes to an hour. So
Okay.
generally, you want to have an an adequate concentration of the antibiotic in the tissues before you make your incision.
So, what is
Hence,
that called?
the Tmax,
Maximum inhibitory effect at the
maximum
tissue level.
inhibitory. Yes.
Okay. What else again?
Then we repeat this
No,
antibiotic.
before you repeat, what choice of antibodies are you using?
Okay, the choices of antibiotics usually depends. Okay, first you use a broad spectrum antibiotic.
One, two,
The antibiotic depends on the local
bactericidal agent.
bactericidal agent, yes.
Yes.
Then the choice depends on the local bacteriological or
So
epidemiological data.
normal commensals around where you're going to be operating.
Yes.
Okay. What else again? So when do you now repeat?
We repeat after about 2 hours of surgery, or
Well,
if
okay.
there
Some
is,
books say 4 hours actually.
oh,
So you
okay,
can say 2 to 4 hours, or if the half life has been exceeded. What else again?
after loss of about 1.5 liters of blood.
Okay, so in a child, maybe a 1 year in a 1 day old, 1.5, does it up to 1.5 liters of blood?
No, not up to
So
1.5.
how many meals per kg?
Uh, I'm not
50
really
meals
sure.
per kg. So
It's
if the patient loses more than 50 meals per kg, then you should repeat. Okay, and then if there's a you can now extend, you can do what they call extended prophylaxis if there's a significant breach in sepsis during surgery.
okay.
So those are the precautions you take when you're giving prophylactic antibiotics.
So about antibiotic stewardship, Dr. Glory, you referred to a set of coordinated strategies aimed at promoting appropriate use of antibiotics. Can you outline briefly these strategies?
Thank you for your question. So the strategies include accountability, drug expertise, reporting, tracking, education. Oh, sorry. Should I explain it as I say it?
You may, if you will.
Okay. So for expertise, um, you would want to have somebody who prior knowledge of the drug and maybe have an education on the drug before the drug is given, knowing the side effects, the pharmacodynamics and pharmacokinetics of the drug. Then for reporting, there should be regular reporting of the kind of antibiotics used by the staffs that are using the antibiotics. Reporting could come from every clinician or including the nurses and any relevant staff, basically. Then education, you want to educate the clinicians about the kind of about the antibiotics, how to use it, the dosage, and
Okay, you also want to avoid overuse, right?
yes, yes,
Yes. Then there's monitoring and feedback with restrictive policies. So when you're talking of monitoring, you want to monitor prescribing habits of all those who are enabled to prescribe. And this enables policies that reduce abusive use of antibiotics. Then alternative treatments such as vaccines and preventative measures that reduce the need for antibiotics in the first place, and global collaboration. So antibiotic resistance is a global issue. So collaboration between countries and healthcare systems is imperative.
Nobody mentioned about superbugs. Those are one of the challenges of antibiotic resistance following indiscriminate use of antibiotics. Okay, Glory, what are the mechanism of resistance of antibodies? Did you mention it?
so I mentioned this in passing. I didn't have time to start going through
Uh,
it.
okay, so do you want to just itemize one, two, three?
Okay, transduction, transformation, and conjugation.
So what are the methods of resistance?
Okay, for transduction, there is a transfer of DNA of a bacterial virus, which is a phage, from one bacteria to another. It's just that the phage, which is attached to the cell wall of another bacteria, I would inject its DNA such that there's like of the DNA of that bacteria. So that when it infects another person, the bacteria is not the normal type, but it's the recombinant type. Then for the conjugation, make plasmids.
Antibiotic resistance, one of the mechanisms is, as she said, um, more like genetic transmutation between a resist or two strains of similar similar genetic makeup or even distant strains. So when there's an exchange of DNA, of course, antibiotics can resolve. Number two, production of enzymes that destroy the drugs, such as production of
Fantastic,
beta lactamase.
fantastic,
Um, the third one, um, change of effector sites or transport proteins
fantastic,
in
fantastic.
the bacteria. Um,
Premature exclusion of the antibiotics metabolites from the
yes,
cells.
yes, sir.
Yes.
Yes, yes.
Okay, well done. Okay, so maybe before you ask any question, she gave us the surgical classification of wounds based on the degree of effectivity. So, do you want to remind us?
Antibiotics can be classified based on their activity, based on their spectrum, and also based on their mechanism of action. So based on the activity, I mentioned that it could be bactericidal, bacteriostatic. Then based on the spectrum, I mentioned that it could be narrow spectrum or broad spectrum. Then based on the mechanism of action, it could be there are cell wall synthesis inhibitors, protein synthesis inhibitors, nucleic acid synthesis inhibitors. Then there are other ones that act as competitive antagonists like sulfonamides.
I think you can also classify them as natural and synthetic.
Slide you showed us. at the tail end of it, which talked about relevance of antibiotics use in Africa and all. I'm thinking it could have been also part of your introduction, because introduction talks about definition, talks about
Historical
statements of
perspective.
the historical part. Everything you can put together briefly that can make people interested in your
Exactly.
presentation.
Fantastic.
Since you will say, and people will turn off their TV, people will shut down, people sleeping will wake up and be interested in listening to you. Those are what forms the introduction. And that last slide seems to be a very beautiful one. So you could bring it to introduction next time if you have the opportunity. Then talking about classification, yes, you did a very good job. But I think I didn't hear much about the gram staining based on gram staining, gram positive and gram negative. That's also an added one. And one thing you should also try and always remember, especially also for the registrars in case of essay writing, you may not remember everything, but some things must just feature in the essay. When you talk about the classification, you must talk about those of the cell wall, inhibitions, protein synthesis, DNA, and RNA. At least those four. Break them down and try and remember at least one or two
examples,
agents that fall into each of the group, and you'll be fine. Then talking about the general principle, just in addition, there is a principle that says you should restrict the antibiotics when there is a known resistance to it. You don't give them. Then when you give the antibiotics, you use some languages that are more of English language and may not be medical. You give the full dose in the appropriate route and the right dosage, not just adequate something else. The appropriate route, the right dosage, and give the full dose. Then also you avoid a broad spectrum antibiotic when you have a suitable narrow spectrum antibiotic. Then also it's very important to note the patient factors. I think you mentioned some patient factors will include age, will include pregnancy, immunosuppression, and all. All these are factored into the choice of antibiotics to be given. Then also the availability, the accessibility, and the affordability of the antibiotic is of importance. Then when you talk about, I didn't hear no slide on antibiotic combination. Please, it's part of it to talk about the indications for antibiotic combinations. And for example, if you have mixed infection, is an indication. When you want to achieve synergism against one type of antibiotic, is an indication. Then when you want to overcome tolerance, then also when you want to reduce toxicity, because maybe the one you are using that is working, you need to increase the dose. You know for sure the toxicity will increase. Then you have to combine with one that is less toxic so that cumulatively toxicity will reduce. Then when you talk about the different the type of antibiotic in use, I was talking about prophylactic, therapeutic, empirical, and definitive. At least in each of these, when we're writing our essays, at least you have the indication for their use, the principle guiding their use, and the route of administration. And if there's any other thing, that's just in summary. Then in the prophylactic use, when you have a wound that cleaning has been delayed for more than 6 hours, that won't deserve a prophylactic antibiotics. Then wound involving the hand and the foot also would require antibiotics prophylactically. Then crush injuries will also require antibiotic use. Then when we're talking about trying to give prophylactic antibiotics 30 minutes to an hour, and also is given at the induction of anesthesia. So you may not give time. You just see at induction of anesthesia. That will also be correct. Then also, how do you assess the effectiveness of the antibiotics you have given? It's different from monitoring. Monitoring, I'm talking about toxicity. How do you assess that these antibiotics are actually working? And that can be divided. It can be clinically, even by checking the body temperature and vitals, you can tell. Then using inflammatory markers. Then also using checking for the contagiousness of the patient. If you've been using a bactericidal agent, if the patient is still contagious after 24 hours, then you are tending to failure. And if you are using a bacteriostatic agent, if the patient is still contagious after 5 days, then it's failing. Then also there should be a slight on treatment failure. In summary, then mechanism of resistance should be discussed, at least briefly, because at least about 3 of them that I can remember. Like the inactivation of the antibiotics, mutation can cause it, then transmission of resistant genes via the plasmids. Those are the mechanism of resistance. Then for my question, what is Jawes rule? This also goes for the registrar. Anyone that could answer it. What's Jawes rule? Thank you. She was trying to explain it at a point, but I doubt if she knew she was talking about Jawes rule. Jawes rule talked about the combination of antibiotics. When we do bactericidal plus bactericidal, it equals, it's equivalent to synergism. When we do bacteriostatic and bacteriostatic, it does additive. It gives an additive effect. But when we do a bactericidal and a bacteriostatic, then it's antagonism. And why is it antagonism? It's antagonistic because usually the antibiotics will function well when the cell is rapidly divided. And when you have used a drug to cause the division to be static, then the cidal cannot do anything. But rather, you have a negative balance in the killing of the antibiotic.